This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending in neurosurgery.
And I'm Dr. Alara, a research fellow. Today we're looking at a fascinating new study from the journal Clinical Neurology and Neurosurgery, published in 2026. It's a comprehensive look at a combined approach for a condition we see almost every day, chronic subdural hematoma, or cSDH.
This is an important one, Ilara. As our population ages, cSDH is becoming increasingly prevalent. We are seeing more older, anticoagulated, and medically frail patients. For these patients, the standard surgical evacuation, while often necessary, carries a substantial perioperative risk and a frustratingly high recurrence rate.
Exactly, and that's what this paper addresses. The title is Combined Middle Meningeal Artery Embolization and Subdural Evacuation Port System Drainage for Chronic Subdural Hematoma, a systematic review, single-arm meta-analysis, meta-regression, and cost-benefit analysis. It's quite a mouthful, but it covers a lot of ground.
It really does. Before we dive into the data, let's talk about the paradigm shift mentioned in the abstract. For a long time, we viewed cSDH as just a mechanical problem, blood in a space that shouldn't be there. But the authors highlight the growing recognition of cSDH as an angiogenic and inflammatory disorder.
Right. It's not just a collection of old blood. It's a dynamic process where leaky macrovessels in the outer membrane keep the cycle going. This study evaluates a minimally invasive strategy that combines mechanical decompression using the subdural evacuation port system, or SEPS, with the targeted modulation of that underlying vascular pathology through middle meningeal artery embolization, or MMAE.
It's a best of both worlds approach. SEPS handles the immediate pressure and MMAE shuts off the tap, so to speak. Now, Ilara, this wasn't just a simple case series. Walk us through the methodology.
The authors performed a systematic review and a single-arm meta-analysis. They didn't just look at clinical outcomes, they also performed a meta-regression and, perhaps most importantly for hospital administrators, a cost-benefit analysis. They were specifically comparing this combined MMAE-SEPS approach against our conventional burr-hole evacuation.
In my experience, burr-hole drainage is the gold standard, but the recurrence rates can be as high as 10 to 20% in some cohorts. What did the meta-analysis find regarding the effectiveness of combining MMAE with SEPS?
The effectiveness was significant. By targeting the middle meningeal artery, they effectively addressed the angiogenic nature of the hematoma. The study aimed to evaluate if this combination could reduce those recurrence rates we worry about, especially in those medically frail patients who might not tolerate a trip back to the OR for a second or third evacuation.
And what about safety? We're talking about adding an endovascular procedure to a bedside drainage system.
The paper found the profile to be very favorable. Because it's a minimally invasive strategy, the perioperative risk remains low compared to more invasive surgical alternatives. For the older, anticoagulated patients mentioned in the study, avoiding general anesthesia or a full craniotomy is a massive advantage.
I found the meta-regression part of the paper particularly interesting. It helps us understand which patient variables might influence the success of the MMAE-SEPS approach. But I want to focus on the health economic profile. In the current climate, we can't ignore the cost.
That's a key point, Dr. Aris. The study included a cost-benefit analysis. While the upfront cost of embolization materials and the specialized SEPS kit is higher than a standard burr-hole tray, the reduction in recurrence is the value driver. If you prevent a readmission and a second surgery, the combined approach becomes much more cost-effective in the long run.
It's about the total cost of care for the episode, not just the cost of the first hour in the hospital. For our residents listening, this study really underscores why we are moving toward these multidisciplinary approaches. It's no longer just see blood, drain blood. It's understand the biology, then treat the biology.
Exactly. The study concludes that for the specific population of older, frail, and anticoagulated patients, the combined MMAE-SEPS drainage offers a compelling alternative to conventional burr-holes. It balances mechanical relief with vascular stabilization.
Well, that's our 5 minutes. A very thorough review of a very timely paper. Thank you, Dr. Ilara. And to our listeners, residents, and attendings alike, keep an eye on these combined endovascular neurosurgical protocols. They are the future. We'll see you next time on the Neurosurgery Hub podcast.